think about that incredible bond you have with your dog. You notice the little things, right? A slight change in their energy, maybe a different way they're breathing. You're tuned in, wanting to understand everything about their health.
That deep connection, that desire to know what's going on. Yeah, that's what brings us here today. We're going to take a real journey into a specific heart condition that affects dogs, dilated cardiomyopathy, or DCM, as it's often called.
That's right. We waded through some really quite detailed medical information, sort of to bring you a clear understanding what DCM is, how it shows up, and, well, what the science is telling us.
Exactly. And the goal isn't to drown you in jargon.
No, absolutely not.
We want to give you, the learner, the crucial insights, connect the dots so you can really grasp this complex topic without needing, a medical dictionary beside you.
Makes sense. So let's start right at the beginning then. What exactly is dilated cardiomyopathy?
Okay. So at its core, DCM involves the enlargement or dilation of the heart's main pumping chambers, usually both the left and the right ventricles.
Dilation. So they just get bigger, stretched out.
Precisely. Think of maybe a balloon being overfilled. The walls get thinner, less effective. And a really key point here, the coronary arteries, the pipes feeding the heart muscle itself, they're usually normal.
Okay, so it's not like a blockage problem.
Not typically, no. The main issue is that the heart muscle itself becomes weak. It doesn't contract properly.
Yeah.
That's the systolic phase, the squeezing part to pump blood out effectively.
Right, the pumping action is weak.
Exactly.
Yeah.
And while that's the initial problem, the systolic dysfunction, things can progress. Later on, the heart muscle might also get stiff and not relax properly to fill with blood. That's diastolic dysfunction.
Oh, so problems filling and pumping.
Potentially, yes. And that diastolic issue, if it develops, often makes the long-term outlook worse.
Okay, so the heart's losing its power. What kind of domino effect does that have, like, throughout the rest of the body?
It's absolutely a domino effect. This myocardial failure, this weak muscle, it directly causes a drop in cardiac output.
Meaning less blood getting pumped out.
Simple as that. The heart just can't meet the body's demands. And that very often leads to congestive heart failure, CHF.
Right. And you hear about valves leaking too. Does that happen in here?
It often does. As those heart chambers stretch and get bigger, they can pull on the structures that support the heart valves, the mitral and tricuspid valves. That stretching can stop them from closing tightly. So you get leaks, valvular insufficiency.
Okay.
And typically we might see signs of left-sided failure. First, think fluid backing up into the lungs.
Like coughing, breathing issues?
Exactly. But it's very common for signs of right-sided failure, like fluid building up in the belly, to show up later on as things progress.
Wow. So this is where it gets really interesting for me. How does a problem just in the heart cause such widespread problems?
Well, think about the heart of the engine, right? If the engine isn't working efficiently, it affects everything downstream.
Yeah, makes sense.
So obviously the cardiovascular system itself is struggling, but the kidneys take a big hit too. Reduced blood flow means they can't filter waste properly, leading to something called prerenal azotemia.
Which is like a buildup of toxins in the blood.
Essentially, yes. Waste products that kidneys should be clearing out.
Okay. And the lungs?
The lungs are very commonly affected, with fluid backing up, causing pulmonary edema. That's the difficulty breathing, the coughing we mentioned.
Right.
But honestly, because cardiac output is down, every organ system is getting less blood, less oxygen, fewer nutrients than it needs. It's a systemic problem originating from that central pump.
Okay. That paints a clear picture. So what triggers this? We hear a lot about breeds. Is genetics a big factor?
Absolutely.
Yeah.
There's a very strong suspicion. And in some breeds, it's basically confirmed that genetics or an inherited susceptibility plays a major role.
Which breeds are we talking about mainly?
We know there are strong links in Portuguese water dogs, boxers, and Doberman pinschers, for example. And what's really fascinating is that the way it's inherited, the specific genetic mechanisms, can actually differ between these breeds.
So it's not just one DCM gene?
Definitely not. It really highlights that DCM probably isn't a single disease. It's more like a collection of conditions with different underlying genetic hiccups, all leading to a similar weak heart.
Huh. Are there tests? Can you test a boxer or a Doberman for these specific genes?
Yes, there are commercial genetic tests available. For boxers, it looks for a mutation in the striatin gene. For Dobermans, it's a gene called pyruvate dehydrogenase kinase 4, or PDK4.
Okay, so wieners can get those tests done.
They can, but here's a really important point. Those specific mutations found in boxers and Dobermans, they don't seem to be the cause of DCM in other predisposed breeds, like Great Danes or Irish Wolfhounds.
Right, so a test for a boxer wouldn't tell you anything useful for a Great Dane.
Exactly. It underscores the complexity. We found pieces of the puzzle for some breeds, but there's still a lot of research going on to figure out the genetics in others.
So what's the focus of that research now?
It's really about understanding that genotype-phenotype correlation, trying to link the specific genetic makeup of a dog within a breed to how the disease actually shows up, how severe it is, how quickly it progresses. That's the key to better risk assessment.
Got it. So with all these breeds involved, how common is DCM? What percentage of dogs get it?
In those breeds we know are predisposed, the estimates are usually somewhere between, say, 0.5% and maybe just over 1%, so 0.5 to 1.1%.
Still relatively low overall, but significant if you have one of those breeds.
Exactly. And interestingly, there's some suggestion the incidence might be higher in certain geographic areas, though the reasons aren't totally clear.
Any specific regions to worry about?
Well, there's one exception, Chagas cardiomyopathy. That's different, caused by a parasite. In the U.S., it's pretty much limited to the southern states, Gulf Coast area.
Okay, but that's separate from the typical DCM we're discussing.
Correct. For the standard DCM, there isn't a strong geographic pattern like that.
Okay, so besides breed, what else defines the typical dog that gets DCM? Age, sex.
Good question. We're talking about dogs, obviously.
Yeah.
Breeds, we've covered the big ones, Dobermans, Boxers, giant breeds like Deerhounds, Wolfhounds, Great Danes, Newfoundlands, also Cocker Spaniels, Portuguese water dogs.
Right.
Age-wise, it typically hits middle-aged to older dogs. The mean range is often cited as 4 to 10 years old.
Okay.
And sex. In most of the affected breeds, it seems males are more likely to develop DCM than females.
Interesting. Okay, so let's shift to what owners might actually see. What are the warning signs? The clinical presentation.
Right. The history. What might you notice at home? Respiratory signs are big. Breathing faster than normal tachypnea. Difficulty catching their breath dyspnea. Maybe coughing.
Okay. Anything else?
Yeah, definitely. Weight loss without trying, seeming really tired or lethargic, not wanting to eat, anorexia, sometimes a swollen belly, that's abdominal distension from fluid, and in some cases fainting episodes, syncope, which are often linked to serious heart rhythm problems, arrhythmias.
Wow, that's quite a range. It's not just one thing.
Not at all. And here's something crucial. Some dogs can actually have DCM but show no outward signs.
Really? So they seem fine.
It's completely fine. We call this asymptomatic or preclinical DCM. The heart changes are happening, but the dog hasn't developed obvious symptoms yet.
How would you even know them?
That's where screening comes in, especially for high-risk breeds. We can diagnose it using echocardiography, that's an ultrasound of the heart,
Okay.
and also by measuring specific things in the blood called cardiac biomarkers,
Yeah.
NT-proBNP, and cardiac troponin in the eye, or CTNI.
Biomarkers, like distress signals from the heart.
That's a great way to put it. Yeah, when the heart muscle is stretched or damaged, it releases these substances, and elevated levels can be a big red flag, even before symptoms appear.
So even if your Doberman seems perfectly healthy, screening might be a good idea.
For high-risk breeds, yes. Discussing screening protocols with your vet is definitely recommended. Now, what might the vet find on exam? It can range from totally normal in those preclinical dogs to really severe signs in advanced cases, weakness, maybe even cardiogenic shock where the circulation is failing.
Yeah.
They might feel a weak pulse in the leg, the femoral pulse.
What about listening to the heart or feeling the pulse? Any telltale signs?
Yeah, they might feel pulse deficits where you hear a heartbeat but don't feel a corresponding pulse wave. That points strongly towards an arrhythmia.
Like atrial fibrillation.
Exactly. Or premature beats, or maybe a really fast rhythm, tachycardia. They might also see pulsing in the jugular veins in the neck, which can suggest leaky valves or right-sided heart failure.
And listening with the stethoscope.
Breath sounds might be muffled if there's fluid around the lungs, pleural effusion, or they might hear crackles if there's fluid in the lungs, pulmonary edema.
Okay.
For heart sounds, they might hear extra sounds like an S3 gallop, maybe soft murmurs from those leaky valves we talked about,
Yeah.
or just pick up on an irregular rhythm.
Anything else they look for?
They'll check capillary refill time on the gums. It might be slow. Sometimes, though not always, you might see a bluish tinge to the gums, cyanosis, and they might feel an enlarged liver, hepatomegaly, sometimes with that fluid buildup in the abdomen, ascites.
It really sounds like a vet needs to put a lot of pieces together. What do we think is actually causing the muscle weakness in the first place? beyond the genetics?
Well, the leading theory, tying back to genetics often, is abnormalities in the proteins within the heart muscle cells themselves.
Proteins, like the building blocks.
Exactly. Proteins involved in the structure of the muscle or how it generates energy, or the actual contractile proteins that make it squeeze. Research is still identifying many of these specific protein problems.
Okay. And what about diet? There was a lot of talk about grain-free diets and DCM for a while. Is there a nutritional link?
That's definitely part of the picture, though complex. We do know that specific nutritional deficiencies, particularly the amino acid taurine and sometimes L-carnitine, have been clearly linked to DCM in certain breeds.
Which ones?
Breeds like Golden Retrievers, American Cocker Spaniels, Newfoundlands, Boxers, even Dobermans sometimes. So nutrition can play a role, absolutely, especially in susceptible breeds.
Are there other potential causes besides genetics and nutrition?
Yes, other possibilities have been proposed, things like viral infections that might damage the heart muscle, or even protozoal infections like the one causing Chagas disease we mentioned.
Sure.
Immune-mediated disease is another thought, the body's own immune system attacking the heart. Certain toxins are known culprits, like the chemotherapy drug doxorubicin.
Right.
And importantly, there are potentially reversible causes that can mimic DCM, severe hypothyroidism, for instance. Or sometimes, just a persistently very fast heart rhythm, a tachyarrhythmia, can tire the heart muscle out over time, fix the thyroid or the rhythm, and the heart function might actually improve.
Okay, so ruling those out is important. If a vet suspects DCM, what's the diagnostic process? How do they confirm it?
Well, first, they need to consider other things that could cause similar signs. The differential diagnosis. Things like chronic valve disease, endocardiosis, which is super common in older small dogs, congenital heart defects, definitely heartworm disease, even primary lung problems. So careful workup is key to avoid misdiagnosis.
Makes sense. What about blood tests? Do they help confirm DCM?
Routine blood work, like a CBC and chemistry panel and a urinalysis. They're often surprisingly normal, especially early on.
Really?
Yeah. Now later, or with treatment, you might see changes. Kidney values might creep up that prerenal azotemia. Maybe liver enzymes get elevated because of liver congestion. Electrolytes can get thrown off by diuretics.
But not diagnostic on their own?
Not usually for DCM itself.
Yeah.
The key lab tests are those cardiac biomarkers we talked about. NT-proBNP and cardiac troponin I.
The distress signals.
Exactly. They're often elevated even before symptoms show up, and they're very helpful for diagnosis and sometimes for tracking severity.
Okay, biomarkers are important. What about imaging? X-rays, ultrasound?
Imaging is critical. Chest X-rays or radiographs are usually done. Early on, they might look normal, but as it progresses, you'll often see the heart silhouette looks enlarged, sometimes quite generally enlarged. And you might see signs of congestive heart failure, like fluid in the lungs or around them.
Okay.
One interesting point is that sometimes, with DCM, the heart might not look as dramatically huge on X-ray as you might expect, compared to, say, a dog with severe valve disease that's causing similar symptoms.
And the ultrasound, the echocardiogram, you said that was the gold standard.
It really is, because echo lets us look inside the heart in real time. We can see the chambers are dilated, enlarged. We can see the walls might be thin. And crucially, we can measure how well that heart muscle is functioning.
How do you measure function?
We use specific calculations, like ejection fraction or fractional shortening. In DCM, these measures of systolic function, the squeeze, are usually significantly reduced.
Okay.
Doppler echo adds another layer. It lets us see blood flow. We can detect leaky valves, measure how fast blood is moving, and sometimes we see patterns suggesting that diastolic dysfunction, the relaxation problem, which can be a negative sign for prognosis.
Got it. So echo gives you the structure and the function. What about the electrical side, the ECG?
ECG, or electrocardiogram, is vital for assessing the heart's rhythm. What's very common in DCM is finding arrhythmias.
Like the atrial fibrillation you mentioned.
Yes, atrial fibrillation is common, especially in Dobermans and giant breeds. Ventricular arrhythmias, like ventricular tachycardia or VPCs, are also really common, again, particularly in Dobermans and Boxers.
Can boxers just have arrhythmias without the heart muscle being weak yet?
Yes, that's a peculiarity in Boxers. They can have a condition sometimes called arrhythmogenic right ventricular cardiomyopathy, or ARVC, where the primary sign initially might just be ventricular arrhythmias on the ECG, even if the heart structure looks okay on echo early on.
Interesting. What else can the ECG show?
It can show signs suggestive of chamber enlargement. The electrical complexes might be wider or taller than normal. Sometimes you see abnormalities suggesting damage to the heart muscle itself. Occasionally, if there's fluid around the heart or maybe hypothyroidism, The electrical signals might look really small, low voltage. So ECG is key for rhythm assessment.
Okay, so let's say the diagnosis is confirmed, DCM. What happens next? How is it treated?
Well, the initial approach depends on how sick the dog is. If they're in severe heart failure, maybe struggling to breathe, they'll likely need hospitalization for oxygen, intensive care, IV medications.
Right.
But many dogs, especially if caught earlier, or if their signs are milder, can be managed as outpatients.
What about things like exercise?
Generally, the advice is to let the dog self-regulate. Let them set their own pace. No forced, strenuous activity, obviously.
And diet. You mentioned nutritional links earlier.
Yeah, diet's important. Initially, if they're sick and not eating well, the priority is just getting enough calories in. But for long-term management, a reduced sodium diet is usually recommended. There are specific prescription cardiac diets.
Do you need to severely restrict salt?
Not usually necessary nowadays with the effective medications we have. Overly restricting salt can sometimes backfire and make them not want to eat, so a moderate restriction is usually the goal.
And what's crucial for owners to know for managing this at home?
Oh, client education is huge. Owners need to know the signs that mean the disease might be worsening, like increased breathing rate or effort, more coughing, less energy, fainting.
Okay.
They also need to know about potential side effects of the medications. And a really useful tool is teaching owners how to monitor their dog's sleeping respiratory rate at home.
Sleeping respiratory rate.
Yeah, count the number of breaths per minute while the dog is sound asleep. If that number starts consistently creeping up, it's often an early warning sign that fluid might be building back up in the lungs. It's a great way to monitor.
That's a great practical tip. Okay, let's dive into the medications themselves. What are the mainstays?
It really depends on the stage and the specific problems. Is there congestive heart failure? Arrhythmias? Low output? For preclinical DCM, especially in Dobermans, there was a big study called the PROTECT trial.
Okay.
It showed that starting the drug pimobendan before symptoms develop significantly delayed the onset of heart failure and prolonged survival in Dobermans.
Wow, so early treatment helps in that case.
In Dobermans, with preclinical DCM detected by screening, yes, pimobendan made a huge difference. That study really highlighted a potential window for intervention.
Does that apply to all breeds?
We have to be careful extrapolating. The strong evidence is for pimobendan in preclinical Dobermans. Starting other drugs early, like ACE inhibitors alone, in the preclinical stage, hasn't really shown a clear benefit.
Okay, so what about when a dog does have symptoms? They're in heart failure.
Right, initial stabilization. If they're hypoxic, they need oxygen. If they're cold, they need warming. Fluids might be given, but very carefully, because too much can worsen fluid overload.
Makes sense.
For pulmonary edema, the main drug is furosemide, a potent diuretic, often given IV initially. Sometimes topical nitroglycerin paste is used to help dilate veins. If there's fluid around the lungs, pleural effusion, it might need to be drained with a needle.
What if the heart is pumping really poorly, like in shock?
For cardiogenic shock, we might use IV drugs like dobutamine for short-term support to boost contractions, or start oral pimobendan right away. And if there are life-threatening ventricular arrhythmias, IV lidocaine or procainamide might be used.
Okay, that's the emergency stuff. What about long-term maintenance therapy?
Several classes of drugs are typically used. ACE inhibitors drugs like enalapril, benazepril, lisinopril are a cornerstone. They help relax blood vessels, reduce workload on the heart. Then there's pimobendan. We mentioned it for preclinical Dobermans, but it's also crucial for dogs with heart failure. It helps the heart contract more strongly, but in a different way than older drugs. And it also dilates blood vessels. It's really improved outcomes.
What about digoxin? I feel like I've heard of that one.
Digoxin used to be a mainstay for strengthening contractions, but pimobendan is generally preferred for that now. Digoxin is still used sometimes, mainly to help control heart rate if the dog has atrial fibrillation, but it needs careful dosing and monitoring.
Okay. And furosemide for fluid?
Yes, furosemide, the diuretic, is usually needed long-term to manage fluid retention, control congestion. Sometimes other diuretics are added, like spironolactone.
Spironolactone.
Yeah, it works differently than furosemide. Blocks a hormone called aldosterone. There's evidence it might provide additional survival benefit beyond just fluid control. Sometimes another one called hydrochlorothiazide is added if furosemide isn't enough.
What about beta blockers?
Beta blockers, like carvedilol or metoprolol, are interesting. They can be beneficial long-term for some dogs, potentially by protecting the heart from the negative effects of chronic adrenaline stimulation. But they have to be used very cautiously. You generally only start them after the heart failure is stable and well controlled, often starting at tiny doses and increasing slowly. They can initially worsen things if started too early or increase too fast, often best done with guidance from a cardiologist.
Right. And taurine or L-carnitine supplements?
The role is still a bit debated for all DCM cases, but there's pretty good evidence they are beneficial specifically for American Cocker Spaniels with DCM and taurine deficiency. In other breeds, if a deficiency isn't documented, the benefit is less clear, though some vets use them anyway.
Okay. And how do you manage those arrhythmias long term?
For atrial fibrillation, the main goal is rate control, slowing the very fast ventricular rate. Drugs like diltiazem, usually in extended release form, or beta blockers like atenolol are common choices. Sometimes digoxin's added to help with rate control. Amiodarone is another option for difficult cases.
And the ventricular arrhythmias?
For ventricular tachycardia, if it's frequent or sustained, we use antiarrhythmic drugs. Oral options include mexiletine, sotalol, procainamide, or amiodarone. Sometimes combinations are needed, bumexaltine with sotalol, for example.
Are there drugs that should definitely be avoided? Contraindications?
Well, digoxin needs caution or avoidance if there's severe ventricular arrhythmia, significant kidney disease, or low potassium levels. Beta blockers and calcium channel blockers like diltiazem can, as we said, potentially worsen heart muscle function initially, so caution is needed.
Any other precautions?
Combining diuretics and ACE inhibitors carries a risk of worsening kidney function, azotemia, especially if the dog is dehydrated or has underlying kidney issues. So monitoring kidney values is important. And be aware of drug interactions. Some antibiotics, for instance, can increase digoxin levels.
Okay. So once a dog is on this cocktail of meds, what's the follow-up like?
Regular check-ins are crucial. Clinical exams, listening to the heart and lungs, periodic chest x-rays to monitor heart size and fluid, blood pressure checks. Regular blood work is key, checking kidney values, electrolytes, especially if they're on diuretics, ACE inhibitors, or spironolactone.
Do you need to keep doing echocardiograms?
Usually not for routine monitoring unless something changes significantly. The clinical signs, x-rays, and blood work often give us the information we need for adjustments. If they're on digoxin, checking blood levels periodically is important.
And owners need to watch for?
Any signs of worsening heart failure, like the breathing rate increasing. Also, potential complications like sudden death, sadly, which can happen due to arrhythmias, and any side effects from the meds, lethargy, vomiting, poor appetite.
It sounds like a lot to manage. What's the overall outlook, the prognosis?
Unfortunately, DCM is progressive. It's ultimately fatal. The average survival time after diagnosis of clinical heart failure is often quoted as somewhere in the range of 6 to 24 months.
That's a wide range.
It is. There's a lot of individual variation. Breed matters. Dobermans, historically, often had a poorer prognosis, maybe 6 months or less, once in failure. But, as we said, with early detection via screening and starting pimobendan preclinically, survival in those dogs is now significantly longer, maybe averaging closer to 2 years or more from that early diagnosis.
Are there specific things that predict a shorter survival time?
Yes. Having atrial fibrillation or significant ventricular tachycardia at diagnosis is generally associated with shorter survival. Certain echo findings, like that restrictive filling pattern suggesting diastolic dysfunction, or very poor systolic function measurements, like a very low fractional shortening or FS%, also tend to indicate a poorer prognosis.
So, wrapping this up, it's clear DCM is a really serious condition. The heart muscle weakens, chambers enlarge, pumping fails. Genetics is a huge player, especially in certain breeds.
Right. And while it's progressive and ultimately fatal, our understanding has grown. Early detection, especially through screening in at-risk breeds and using medications like pimobendan early, can make a real difference in some cases.
And for dogs already showing signs, a multi-drug approach targeting fluid, vessel tone, heart contraction, and rhythm is key to managing symptoms and potentially extending good quality life.
Exactly. It's about managing the different facets of the heart failure.
So hopefully you, the learner, now have a much deeper grasp of DCM, moving beyond just the name to understand the mechanisms, the diagnosis, the management strategies.
Indeed, and it leaves us with something to think about, doesn't it? Considering that strong genetic link in so many breeds, what are the implications, maybe the ethical considerations around genetic testing, breeding practices, and trying to prevent this in future generations of dogs? What further questions does this deep dive start for you about the incredible complex canine heart?